work group. All right, check, got it. This is our first meeting of a series in which we will be developing a set of recommendations to go in a legislative report that will respond to language in a budget proviso for us to examine a pathway or what it would look like or take to have a pathway similar to what Oregon has established related to the use of psilocybin. We will be hearing in great detail language about the budget proviso, or in more detail, as well as from the folks in Oregon, how their current efforts are going and what they're doing. Our mission as a committee is to look at the language, get whatever information we need that we may not already have access to, have, I hope, robust conversations, and respond to the questions in the proviso for the purposes of the report. The Healthcare Authority is the state agency that is the single state authority for Medicaid. It is also the agency that provides for the administration of the health plan benefits for public employees, as well as school employees and their beneficiaries. We do not have licensing functions. We'll hear from the Department of Health about their scope, but we create Medicaid policy, we manage the Medicaid programs, we work with our other state partners in the long-term care areas, developmental disability areas. We figure out what drugs are covered, we figure out what clinical services are covered, and we are driven in that by legislation that requires us to provide coverage for medically necessary services, for which there is a pathway in which we're to follow that relates to the evidence supporting an intervention for a medically necessary service. I say that not because it's necessarily pertinent to this, but again, we are the Medicaid agency. We know right now that psilocybin is a Schedule I drug. It is not something that Medicaid can pay for, maybe someday in the future, but it is not an option now. So it is, I think we were asked in part to do this because we have a lot of the healthcare responsibility, purchasing and payment. So I just wanted to say that. I think that a couple other things, I want to go through introductions. I'm going to stop there and we can comment more. I do want to welcome our partners in this work from the Center for Evidence-Based Policy at the Oregon Health Sciences University. They will introduce themselves as we go through introductions. They have been partners with us in this work. They will be managing a lot of the meetings. They will be ultimately writing the report and helping us to gather all the information so that we can respond to the proviso language with our charge. So that is, we are, that's kind of where we are. So in terms of the chat, how we are going to do this, just quickly, I want to go through introductions, and I'm going to come back and talk about, actually, I'm going to hold off on introductions for a minute. So I want to talk a little bit about the mechanics of the meeting. We know that this is a very current and topic with a lot of interest. We also know that these are public meetings, and we are going to do a couple things given the time that we have, the amount of conversation we're hoping to have across the committee. We are going to ask that if you have comments, we will share this website right here. This is not for committee members, but for any public comments, we would ask that you please submit them here. And we will gather them in that point. The chat isn't always reliable. We can't necessarily keep a record of it. So we ask that any public comments be sent to this website. If there are comments from the committee, please either feel free to speak up or use the chat, and we can respond to those. The other piece to ask, actually, and I'll do this after we have the committee introduce itself, is we'll talk a little bit about public meetings, in person, private, sort of our open public meeting rule. And we'll do that after we have a chance to meet everybody on the committee. So before I turn it over before I go through and ask for introductions, a little bit about myself. As I mentioned, I'm Charissa Fotinos. I'm the Medicaid Director of the Healthcare Authority and the Behavioral Health Medical Director. I am a board certified family physician, addiction medicine physician, and have cared for folks in primary care for a number of years, including folks with serious mental illness, mild mental illness, and with all variety of substance use disorders. So do have some clinical perspective I can bring to this, as well as sort of what Medicaid can do. And to answer your questions, yes, if there is a medical necessity for health and therapeutic service to be provided during the course of a visit by a licensed healthcare provider, yes, that could be paid for by Medicaid. So I want to stop there. A little bit about me. I want to also ask Cody, who is going to be, if you've not met her, she's really kind of keeping all of the information together, providing all the support in terms of meeting notes, web support, help getting questions to the right places. So Cody, would you mind introducing yourself so folks have a face with the name?
Sure. My name is Cody Campbell, and I'm just providing administrative support to this work group.
Thank you, Cody. I'm just going to go down the list of work group members, recognizing that we may not have Pablo still, but Dr. Agarwal.
Hi, good afternoon. Thank you. I'm Sunil Agarwal. I'm a physician as well. I'm in hospice and palliative medicine and physical medicine and rehabilitation. Those are my board specialties. I've been in practice for, I graduated in 2010 from the University of Washington, so it's been about 12 years. I'm also a geographer, a health and medical geographer. I have my doctorate in that area, and I have a special interest in the human entheogen relationship and how it applies to public health and ultimately a peace settlement, a drug peace settlement, which I think is very badly needed in public health. So I'm glad to be here. I work at the Ames Institute in Seattle, and looking forward to meeting all of you and working together.
Great, thank you, Sunil. Ada, and I apologize if I mispronounce anyone's name, Ada Danilo.
All good. It's Ada Danilo. I'm a lawyer at Civet Law Group, and I am on this committee through the Q Law Association of Washington, which represents the LGBTQIA population, especially from the attorney side. So excellent. Glad to be here. Welcome.
Ada, correct?
Ada Danilo, yeah.
Great. Okay, thank you. All right. I'm gonna I could say it right or wrong, and I'll probably pick the wrong one. Hermaine Danabal?
Really close. I'm Jermaine D'Annabelle.
Jermaine D'Annabelle, yes. Okay.
And I'm a psychiatric nurse practitioner with, I worked as a primary care, direct care nurse from 1980 until the mid 90s when I got my master's in psychosocial nursing. I'm board certified as a clinical specialist in psychiatric mental health nursing. I just retired in December from a private practice of 20 years doing psychotherapy and psychopharmacology. And I also have worked in public sector psychiatric mental health clinics, as well as in primary clinics. And I have done some cross-cultural work, both as a nurse volunteer in Zimbabwe and Malawi in the mid 80s. And then I worked at the Seattle Indian Health Board from 1988 till 95. Oh, I also worked at Northwest Family Center, which was the women's and children's HIV clinic at the public health department. So those are the things that I bring to the group.
Great, thank you for sharing that. Lacey Fehrenbach.
Good afternoon, everyone. I'm Lacey Fehrenbach. I'm the Deputy Secretary for Prevention, Safety, and Health at the Washington State Department of Health. My background is I am a trained public health professional. background in maternal and child health primarily, as well as health policy. I recently led the COVID-19 response at DOH and continue to do some of that work as well. But really here today with respect to DOH's role in ensuring access to safe, quality healthcare, and that involves the regulation of healthcare professionals, 400,000 plus of them across the state of Washington, and healthcare facilities, I believe about 11,000. We also run the medical cannabis program here in Washington state, do things like set standards for manufacturers of drugs to avoid or prevent human health harms. And then in our prevention arm of the department, run a number of preventive health programs related to mental and behavioral health and overall life course wellness, and some health education and communication efforts for Washingtonians. And really delighted to be here with you all today and engage in this work with you.
Thank you, Lacey. Kate Foster.
Hi, thank you. I am very curious and excited to be included in the work. Thanks so much. I am a private nurse advocate, and my interest in this is sort of twofold. I have a lot of clients. I don't do psychosocial nursing, but I have a lot of clients who are interested in this for end of life and psychiatric choices. So I'm curious about it. And I also work in youth substance use prevention. I work for WSU, and I'm on a lot of prevention coalitions regionally and locally. So I kind of am coming at this from both angles, and I'm just really curious to see how it unfolds. Thanks for including me.
Oh, thank you. Jeremy Grisham. Is Jeremy with us today?
He's the one that I wasn't able to confirm, so it looks like he hasn't joined yet.
Okay, we'll come back to him if he is able to join. Dr. Jay Kennedy.
Hi, I'm a professor of community health at Washington State University, but on this committee I'm serving as a disability advocate. I've been at WSU for about 20 years, but I've been in disability advocacy for about 35 years. And I've had chronic depression since childhood. And my depression is managed fairly well by conventional antidepressants, but I have a son who has treatment-resistant depression, so I've got a lot of personal interest in getting efficacious, affordable treatment options to people with serious mental illness.
Great. Thank you, Dr. Kennedy. Emma Knighton.
Hi everyone, good to be here. I'm Emma Knighton. I'm pretty sure I have COVID right now, so if my voice is, so just bear with me here. Feeling okay though. So I am a somatic trauma therapist in Seattle, and I specialize in working with people with complex PTSD from a variety of childhood abuse, particularly work with folks who've experienced sexual abuse, abandonment, and neglect. And there's a big intersection in my practice in working with the queer community, which I am a part of. I'm also a above ground trained psychedelic assisted therapist and have done some of that work in the past and currently do a lot of preparation and integration work for folks working with a variety of medicines in all sorts of settings. Additionally, I'm the co-executive director of the American Psychedelic Practitioners Association, which is the national professional association for the psychedelic healthcare space. And we do things like, well, we're currently in the process of setting ethical guidelines, standards of care, standards of training, and the accountability process for the eventual field of psychedelic healthcare through rescheduling at the federal level. And in that work, I do a lot of effort around equity and anti-oppression practices as we're intersecting with the healthcare system. And then the last piece of what I'll be bringing to this committee is I teach in a handful of the above ground psychedelic facilitator trainings, and my specialty is trauma-informed consent practices and making sure that those are integrated with psychedelic assisted therapy. And really excited to be here with everyone. Thanks.
Great, thank you. Seth Mayer.
Yeah, hello everybody. My name is Seth Mayer. I am an advocate for veterans. I've been an advocate for veterans since my exit from the military in 2005. I am a 100% service-connected disabled veteran, polytrauma, both physical injuries and moral injuries, including military sexual trauma. I'm also treatment-resistant depression, and so I'm an advocate for veterans and the elimination of all forms of suicide, but not just for the veteran population, for anybody who's suffered trauma. And I stand behind this medicine that can help with this. Thank you for having me.
Yeah, no, thank you, Seth. Dr. Elvina Morris. Probably said it wrong.
Good afternoon. My name is Elvina Maris. I'm a clinical psychologist and also a Cobble Tribal member. I currently am working as a behavioral healthcare manager at a local rural hospital. My background is working with both rural and urban tribal behavioral health populations. So working with a lot of trauma. And my interest in this is, and then I'm also currently going through a psychedelic assisted therapy training program. I'm interested in those medicines that are more closely aligned with tribal peoples, like cultural and traditional practices. And so I am very interested in this work. Thank you for letting me be here.
No, thank you. Kelly McLean.
Good afternoon, everyone. My name is Kelly McLean. I'm the Washington State Department of Agriculture's policy advisor that's been assigned and designated by the director to participate in this work group. Part of my work includes all of our work in the cannabis and hemp space, as well as our work in the safe production of any grown commodity that would be ingested. And so I'm really excited to be here and look forward to the discussions and conversations that will lead to the recommendations report this fall. Thanks.
Thank you. Jim Morgan.
Hello, I'm Jim Morgan. I'm the Chief Financial Officer for the Liquor and Cannabis Board, but more relevant to this discussion, I'm the executive sponsor for the project for our new cannabis tracking system. And my role here is to help determine if that system or a system like it would be useful for this effort. Thank you.
Thank you. Dr. John Roll.
Hello, everyone. My name is John Roll. I'm the Vice Dean of Research for the Washington State University College of Medicine and the Chair of the Department of Community and Behavioral Health, as well as President-elect of the Washington State Academy of Sciences. I'm an experimental psychologist who's trained as a classic behavioral pharmacologist and thrilled to join you all today. Thank you.
Thank you. Dr. Tony Rusmanier. I'm going to mess it up.
That's okay. A Rumanier, thank you. Hello, everyone. Great to be here. I'm a clinical psychologist in Seattle. I specialize in therapist training. I'm an editor of a book series for the American Psychological Association that focuses on therapist training. I'm a member of the Washington Psychological Association and recently was elected incoming president of Division 29 of the American Psychological Association. I'm really excited to be here, especially see how I can contribute in relation to working with psychologists in the state of Washington. Thank you.
Thank you. Dr. Nathan, oh, nope, Dr. Caitlin Ryan.
Good afternoon. My name is Caitlin Ryan, and I'm board president of the Cannabis Alliance. I just stepped out of the role as interim executive director. My background is actually arts education, and I've been working in cannabis policy since the passage of I-502 at the municipal, state, and federal level. And my role here is to hopefully steer us away from some of the pitfalls that we've experienced in the legalization of adult use cannabis, as well as a deep personal interest with both myself and family with treatment-resistant mental health issues. So thank you very much.
Thank you. Dr. Nathan Sackett.
Hello, everyone. My name is Nathan Sackett. I'm a physician and I'm an assistant professor at the University of Washington in the Department of Psychiatry, where I spend half my time working with general psychiatry patients as well as addiction patients. And then I spend my other half of my time, I'm the director of a new center called the Center for Novel Therapeutics, where we're focusing on exploring the use of psychedelics to treat substance use disorders, where we hope to do clinical trials as well as training and education in this space. So I'm excited to be here.
Great, thank you. Paul Stamets, I believe you might be on a plane. I'll wait a second or two. I think you're on the phone. We'll assume you are hopefully boarding. Cody Zolowski.
Zolowski. Anyway, thanks everyone. Hi, my name is Cody Zolowski. My background is in medicine and clinical research, particularly in neurobiology and neuroimaging across a variety of modalities. I am co-director of the Psychedelic Medicine Alliance of Washington. Our organization advocates for equitable, affordable, and natural psychedelic plant and fungi medicines here in Washington State. We've been behind several of the local pushes for reform here in this area here in Washington. And we're looking forward to help move the debate on providing expertise in this topic in light of all of the recent published literature, and excited to be here.
Great, thank you. Dr. Judy Zerzan.
Hello, I am Judy Zerzan-Thule. I'm the Chief Medical Officer at the Washington Healthcare Authority, and I am here to help support from HCA's perspective. Looking forward to the conversation. Thanks.
Great, thank you. I believe that is all the committee members. We're just about on time, unless somebody here jump in on his behalf. Yes, Renee, please, if you would, just introduce yourself on Paul for sitting in for Paul today. Thank you.
Hi, everyone. My name is Renee Davis, and I'm the Research and Development Director at Fungi Perfecti, which is Paul Stamets' company. And we're really leaning into this conversation with the mushroom cultivation, production, and a mycological perspective. So what we're really considering as we talk about some of these different policies and legislations are some of the knowledge gaps that are existing in the evidence base. For example, some of the differences between natural and synthetic psilocybin. The current biomedical evidence base really concerns synthetic psilocybin, but real world use is around natural psilocybin. So what are the differences there? There are also hundreds of species that contain psilocybin, but what do we know about them? There are conditions like wood lovers paralysis and other subjects that are relevant to public health and safety. So we're considering, like, could there be space for wild collections in this legislation? How can we cultivate mushrooms for research purposes? So those are some of the things that we're thinking about as we consider this in Washington State. So we're really excited about what's taking shape here, and thanks so much for having us.
Yeah, thank you. And, you know, our intent is to have a lot of time for discussions to, you know, share both our individual areas of expertise and you know, come to the best we can to recommendations, as it were. I just wanted to add a couple more things that may help inform a little bit of my perspective as I approach this work. As I mentioned, I'm a family physician and addiction medicine physician. I taught in a family medicine residency program for 10 years. And over the course of that time, had a lot of clinical interaction, both with my own practice as well as with the residents' practice. So I bring that sort of training perspective to it. I also have a master's degree from Oxford University in evidence-based healthcare. I will caveat with the fact that recognizing that it does not afford or allow, nor does that contribute to understanding of any cultural practices or religious practices that aren't going to be studied in that setting. So I recognize both are true, but as a physician, I kind of start with a medical lens and then I go for there. So if that's where my comments come, that I just wanted to sort of put that out there for folks. I'm going to quickly talk about public meetings and our responsibilities. The governor rescinded his emergency proclamation related to public meetings. What that means is that we have the option to have hybrid meetings or solely online meetings. That is something that this committee can decide. I will say that our director of the Healthcare Authority has continued to not allow any meetings within our facility with non-agency employees. We have vaccine mandates, so we are not able to meet in that setting. I know that people are attending from different parts of the state. It is my and our recommendation as the folks sort of managing the work of this committee that we continue to meet virtually. We don't have any allowances to pay for people to travel. We would have to find another location that was agreeable for everybody and figure out how to pay for that. And we don't really have any funding to do that. So I would ask that the committee consider continuing the meetings virtually unless there is strong opposition, and we can talk about that. But I don't know that we need to take a vote now. But perhaps if you have comments in the contrary, you could put those in the chat. I recognize we're a little bit over on time. So if folks could do that, that would be great. I now want to turn it over to Mike Bonetto, who's going to lead us through the next part of the agenda.
Charissa, thank you so much. Cody, if I can ask, or if it's Beth, can we go back a slide up to the agenda? Thanks. I just wanted to take a second here. So guys, thanks again. As I said it earlier, I'm Mike Bonetto with the Center for Evidence-Based Policy out of OHSU. I have some other colleagues. I'm not going to ask them to introduce themselves, but I just want to quickly go through if you see them on the list. We have Beth Church with us today, Haley DeCarolis, and Duncan Stewart and Susan Stewart, part of the entire team that we've been kind of working behind the scenes of really kind of helping kind of gather some material and then teeing things up for today's first meeting. I also wanted to certainly, as you look on this agenda, part of this discussion today is dependent on two key people, and we just can't thank them enough. You'll see Sam Chapman, Executive Director of the Healing Advocacy Fund, and Angie Albee from OHA, who's managing the Oregon Psilocybin program. We're going to hear from both of them today. They both have made kind of a time allocation today just to get through this. And I think they both have hard stops. Sam has a hard stop at 2, Angie has a hard stop at 2:30. So we really want to make sure that we have time to hear them and then have time for you guys to have some interaction with them. So my section right now is going to try to go through it as quickly as I can to tee things up just in terms of where we are, and then turn things over to them. And then we'll have some time after that to go through some discussion with you, talk about the results of the survey that you guys did, and then talk about even some next steps. Okay, thanks. Let's keep going forward. So I just want to make sure we're kind of all on the same page. Then the next slide, as we kind of review this legislation, Charissa mentioned this part of this budget proviso that came out of 5693, and it really is then setting the stage and directing HCA to go through this process of kind of convening a group just like you guys, and then going through these specific points. So one is really reviewing what has Oregon done, right? And we're going to hear a little bit about that from Angie today. We'll probably go into even more detail over the upcoming meetings, and really understanding kind of what has been done in Oregon, what's potentially applicable in Washington. We heard that Jim Morgan from Liquor and Cannabis Board is here. We're going to learn more about then what would have to be done with Liquor and Cannabis Board to do something like Oregon has done, right? So we want to have a better understanding of that. And then the next slide outlines 3 other points that were outlined in the legislation. And this is to examine kind of this social opportunity program that was put in draft form with Senate Bill 5660. And we'll talk about that in just a second, because there are some bigger pieces around 5660 that did not pass. But this bill is asking this group to review some of those components. And one of them is that. And then this second bullet you see there again, a piece of 5660 wanting to understand, so what is the infrastructure capacity needs that the Department of Health would need to launch such a program? And then I think, as you heard earlier from the Department of Health, of just what's the licensing requirement that would potentially be needed, and what are kind of those options. So again, maybe some lessons learned from Oregon, what would we want to think about for Washington as well? So that really kind of encompasses a lot of the work that we're going to be doing over the next several months. And the next slide, and again, these slides will be available. We'll get these out to you right after this. This just shows this side-by-side comparison, just to make sure we're kind of clear. So there is these references to Senate Bill 5660, and this is a high-level snapshot of what was in that bill over kind of these, what do we have, 4 bullets there. But the bottom line is 5660 did a lot of mirroring of what was in the Oregon statewide ballot measure 109. So very kind of similar structure. The budget proviso bill of 5693 didn't take that route. They just said, hey, let's set up a work group and do this first step of analysis. So just want to make sure you guys understand the comparison. So 5660 really was very Oregon-like. 5693 is really doing what you're doing right now, is kind of having kind of experts across the state looking at this and starting to make some recommendations and then report back to the legislature. Great. So next slide.
I'll just chime in here as quickly, Mike. Licensed behavioral health professionals. Do you think that the idea with it was there to not think about a whole field of health professionals, or?
Sunil, it's a very good question. I mean, I think that's part of the interpretation that this group is going to have to make of what we mean by that. I think and I think we can hear from Angie and Sam the way Oregon's looking at that. I think we're really looking at these kind of certified facilitators, licensed facilitators. So there's a question of just, how that plays out. Certainly there are going to be implications on the reimbursement side of how, even health plans or anybody else would be able to reimburse if it's not a licensed healthcare professional. So I think that's to be explored. So I think fair point.
Yeah, I was not licensed, non-behavioral is what I was sort of saying, but I understand the distinction between licensed and non-licensed, but I think it's interesting to think about all licensed health professionals as well, not just behavioral.
Absolutely. Great point. So again, basically looking at, we've got 5 meetings that we have been able to outline and trying to kind of go through these steps sequentially so that we really have some time to go through each of these. Kind of what we're going to be doing today. We want to hear about it, right? So if you guys have a better understanding and then have some group discussion. I know we've got a big group, but we really want to do as much as we can and facilitate that discussion. So we'll kind of go through those in sequence. And then the next slide. We have some specific kind of requirements in terms of deliverables. And I think Charissa mentioned this earlier. So a preliminary report by December 1 of this year, and then a final report December 1 the following year. So what we're looking at doing is kind of having these initial drafts done for year review. And then there's an internal process at HCA that those reports have to go through to get finalized. So we've kind of put that into the overall work plan. And if we go to the next slide, I'll show you that. So again, this is at a high level that here we are on June 30th, our very first meeting. We've got our next meeting already scheduled for August 4th, but you can kind of go down this road. So we look at having this preliminary report just based on those first 2 meetings in mid-August, have the third meeting in October, that first report put out in December 1, and then those meetings 4 and 5 in March and May. In between, you'd be reviewing kind of that final legislative report, and then the final report due in December. So a lot of work, not a lot of time, but after you guys just went through introductions, I just feel like this is an amazing group. So I feel like we definitely have the right people around the table, which is fantastic. Thoughts, comments, questions? I know I went through that quickly. I just want to make sure I can turn things over to Sam so he has enough time to kind of go through his overview of 109.
Mike, just a really quick question. I put in the chat. How does this group decide things? Like, do we have to have quorum? What's percentage needed to actually make a decision? That just was important for me.
Yeah, no, Emma, great question. I think we were looking at potentially majority vote. Again, these are recommendations that you are making kind of as a whole, and we can certainly record those. If there's not consensus or if there is a majority, we can record that in the report and hand that over to the legislature, and the legislature can kind of weigh those options. If that makes sense.
Okay, so majority being 51%.
Correct.
Okay, thank you.
Correct. Other thoughts, questions? Okay, Sam Chapman, are you around?
I am.
Well, thank you so much, Sam, for being here today. I think we are looking forward to getting a little better educated on a Oregon overview. And I'm going to, before you start, I see Senator Solomon has his hand up. So I thought, Senator, quick.
Hi.
Yeah.
Can you hear me?
Yeah, we got you.
Good. Thanks you all for being here today. And I just want to say that I'm interested in the reasoning. So if there's not a majority vote, but somebody feels like they want to do a minority report, I'm not just going to be looking at, how many votes there were, but like what the thought process is, and that will help me formulate next steps for a bill.
Thanks, Senator. I think that's a great point. So we would definitely, that was kind of my key thing. I want to be sure we're capturing all of that input and being able to put that in the report.
Thank you.
Great. Sam, you've got control?
I do indeed. Give me 1 second to pull it up. And let's start. All right, can everyone see that? Good.
Got it. Thank you. Yep.
Okay, cool. Thanks, Mike. Hey, everyone. Again, my name is Sam Chapman. I use he, him pronouns. For context, I was the campaign manager for Measure 109. Prior to that, I've been involved over a decade in progressive drug policy reforms at all levels, federal, state, and local. And now I serve as the executive director for the Healing Advocacy Fund. And our mission as a 501c3 nonprofit is to support the thoughtful and effective development, implementation, and education of the nation's first psilocybin therapy program, which Oregon voters passed in November 2020. And I'm going to try and actually zip through this in under 20 minutes. So we can have a little bit of time for questions if possible. But otherwise, I'll defer to Mike. I know my colleague Angie also has just about all the information I'm sure I have as well. So we'll go ahead and dive in here into Measure 109 recap. And this is a little bit just of the problem statement, which I think most people are familiar with, but it's worth reading anyways. Prior to the pandemic, CDC was basically saying 1 in 5 Americans were experiencing clinical anxiety, depression. Now that's 1 in 3. Here in Oregon, the mental health crisis is even more acute, with Oregon having one of the most severe mental health crises in the country, and that was prior to the pandemic hitting. Again, which I know a lot of folks on this call are very well familiar with, is the research, especially over the last 5-6 years, that has been coming out of incredibly prestigious institutions from UCLA to NYU to just recently the University of Alabama. In addition to the fact that the FDA has also granted psilocybin with a breakthrough therapy designation, meaning that it may demonstrate substantial improvement above and beyond what is currently available. I think that also helps highlight some of the hypocrisy of psilocybin being a Schedule 1 at the federal level. That's a political designation, not a medical one, in my personal opinion. So to the measure, the goal of Measure 109 is fairly straightforward. Create a licensing framework to allow those who seek psilocybin therapy that can safely benefit from it. Here's a couple of the pillars of what Measure 109 does. First, it establishes a regulatory framework within the Oregon Health Authority that will allow trained practitioners to administer psilocybin services at specially licensed centers. It also establishes a psilocybin advisory board that is appointed by the governor. We'll talk about the membership in a couple of slides. There is a 2-year development period before licenses are granted. We're about 3/4 of the way through that process. And I know that I'll speak to that a little bit. Angie from OHA will also speak to that in much more depth. The measure also requires the establishment of training and licensure system for psilocybin facilitators, manufacturers, service centers, and testing labs and training programs. And of course, there's also the establishment of a tracking system for all psilocybin products. Just as important, and sometimes more important, depend on who you're talking to, especially as a state that already has adult use cannabis, is what Measure 109 does not do. Does not allow retail sales. There is no off-site consumption, possession, or cultivation of psilocybin. There is no branding or advertising of psilocybin products. You're not going to drive down I-5 and see any billboards with mushrooms on them. There's no unregulated, untracked production, inventory, or delivery. Service centers are not allowed to be near schools, and you must be over the age of 21 in order to access psilocybin services. So this is a little graphic that we put together. There's a lot more depth to the process that will exist for psilocybin services and accessing them, but we feel like this is a decent representation of the general 4 steps. The first is assessment. This is where someone seeking psilocybin services will go through a process to share their general health history with a facilitator that really allows the facilitator to get a better sense of what background this person's coming from, better understanding why they're seeking psilocybin services. And I think one of the more important facts is understanding whether or not they're a right fit, right? Whether it be personality or background and training, right? People in Oregon do not have to have a qualifying condition in order to access services, and that was very intentional. There's plenty of people who will be seeking services for general wellness, and there's a good number of people that will be seeking services for severe depression, anxiety, other things that folks have mentioned here. And we felt it's very important that we created a measure that allowed access for the broad spectrum of people that we feel can benefit. So the second step is intention setting. This is ideally where the participant and the facilitator will meet to really, again, understand their compatibility and kind of allow the facilitator to, continue to work with that client to develop a relationship and ensure that everyone involved is ready to move forward into the third step, which is an administration session. This is where the psilocybin will be administered, again, at a licensed service center by a trained and licensed facilitator who will oversee the session throughout the entire process and will certify the completion of the session as well. No one will be leaving the center under the influence of psilocybin, and there will be a robust safety plan that will actually be required at the beginning of this process to ensure that people have transportation afterwards arranged and things of that nature. And last but certainly not least is an integration session. This is mandatory for facilitators to offer. However, it is optional for participants to take. This is, as I think a lot of people here probably know, a lot of the research is showing the more integration that people can do to unpack their experience, come back and unpack their experience with the facilitator can often help prolong the positive benefits of the session itself. And so those are the 4 very high level steps of psilocybin services under the Measure 109 program. Moving into a little bit of the implementation here. So as I mentioned before, we are about 3/4 of the way through our 2-year development period. The Psilocybin Advisory Board just advanced their final recommendations to the Oregon Health Authority. And again, these are the 4 license types that exist under OHA as facilitator, manufacturer, service center, and testing labs for psilocybin products. A little bit about the Psilocybin Advisory Board. So they were tasked with a handful of things. They collected all of the existing studies to date on psilocybin. So there's an entire compendium that now exists on the OHA psilocybin website, which is a great resource for anyone that is purely starting from scratch. I would encourage folks to assume that anyone that you're talking to is probably starting from scratch. Maybe they've heard some things, maybe they read Michael Pollan's book, etc. But what we're learning here in Oregon is it's been 2 years. A lot of people still have no idea what psilocybin is. I do not expect that to change in Washington, and I suspect that's probably the case in the Washington legislature generally as well. So the studies really laid the foundation. Other duties of the board are to recommend guidelines for serving clients, licensed facilitators, service centers, establishing public safety standards, professional conduct, certification, training requirements, and developing a long-term strategic plan for ensuring that psilocybin services will be accessible and affordable as a therapeutic option. That is easier said than done. I'm sure that between Angie and I, we could probably write an encyclopedia of our experiences thus far, both inside and outside of the regulatory sphere. And I think there's going to be a lot of opportunities, not just to ensure that the foundation of the program here in Oregon is based in science, facts, and safety and access, but the future ambitions to continue to expand to ensure that anyone who stands to benefit can and does have access to psilocybin therapy over time. And of course, the board is also tasked with monitoring and studying federal law and has the ability to establish subcommittees, which they absolutely did. Moving forward here, as you can see, we have a pretty stacked advisory board. You'll also see that there's a handful of doctors here. There's folks who represent different agencies that are involved, and there's also folks from the community here. And I think, this board has done some really incredible work in a short amount of time. That was one of the things that we felt very strongly about, was giving ourselves 2 years to figure this out. As the first state to move forward with this, we understand the responsibility of going first and getting it right. It's not going to be perfect by any means, but the foundation will be solid and set in safety and public education and accessibility. And we think that the board has done an incredible job, and we're looking forward to the final rules coming out and codifying and getting started in 2023. So here is a very, very high level timeline. I also want to acknowledge that Angie from OHA is probably going to share a much more detailed timeline. But as you can see, we are just at the end of this June 2022 rulemaking mark, where the advisory board again has passed along all of their recommendations to the OHA. And Angie will talk more about kind of the process moving forward. But essentially between June and December, the rules will go through several iterations. Public will be able to weigh in. There'll be rules advisory committees that will be conducted to take an additional input. And on January 2nd, 2023, the OHA will open up the application process. I think the other thing that's worth mentioning is thanks to the OHA, we were also able to expedite a set of rules ahead of time, specifically on training programs and products. This was something that we worked collaboratively with OHA on, and everyone recognized that if we are to aim for services being available at any point in 2023, we needed to be able to start training facilitators earlier on so a cohort could be ready. There is absolutely a lot of importance placed around the order of operations of things. And while there are certainly still some chicken and egg issues that we're all gonna work together to solve, I am incredibly impressed and just happy with the progress that we've been making. We are on timeline as the measure requires. And of course, there's always going to be new challenges and problems that come up. But again, as the first state to move forward on something like this, we see those challenges as opportunities to work together, to work collaboratively, and to work for the people who stand to benefit from this program across the board. So the last slide is the latest wave of essentially my day-to-day life, which is local control. This is under Measure 109. Cities and counties have the ability to opt out of the program if they want. All of them are currently opted in right now. If a city or county decides that they do not want to be a part of this program, there's a two-step process they have to go through. The first is a city or a county's elected folks will vote to put it on the next general election ballot, and the residents of that locality will then vote on it. And that is one option that we are working to educate all localities here in Oregon, so they have all of the information. Again, most of them think that this is cannabis. So we are actually starting with, this is not cannabis. There are no retail sales. There is not going to be light pollution from production. There's a lot of things that they have knee-jerk reactions due to cannabis that I think would not be surprised if similar concerns came up in Washington. The other two options they have are adopting reasonable time, place, and manner regulations. This is essentially hours of operation and zoning considerations. And they also don't have to take any action. There is a lot built into the 71 pages of Measure 109 here in Oregon that speaks to safety, that really lays out all the process. And it's easy enough for a locality to just add these businesses to an existing code that they have. So their job is pretty easy too. I could go on forever about local control because we're in the middle of it, but I will stop there. And as Mike mentioned, I also have a hard stop at 2 p.m. My apologies. But please do not hesitate to reach out. I'm happy to be a resource. I will admit I have to keep my blinders on a little bit in terms of the massive project that we have here in Oregon, which stands to have an impact one way or another on other states coming behind us. But I will do anything and everything I can to be a resource. And as it relates to more of the education side of things, I also have additional information from the campaign, exit polling on how we moved people in education, what the best type of education was, how it moved people, what demographics it moved, and would be happy to talk about deeper strategy if and when individuals or this group is interested in that as well. So with that, Mike, I'll go ahead and yield it back to you.
Well, Sam, thank you so much for taking time to do that. I know you got maybe a couple minutes here. I was just checking the chat as folks were kind of weighing in. Any comments on microdosing? I know this has been a comment. We did a survey too. There was a lot of comments on microdosing. Can you just talk about kind of the framing of 109 and how that stands in comparison to microdosing?
Yeah, absolutely. I mean, the first thing I want to acknowledge is, there's a ton of interest in microdosing, and I think naturally so. I think it's a stepping stone into learning about the larger psilocybin macrodose in general. What I will say is that Measure 109 was not built with microdosing in mind. It does not prohibit a microdosing model, but it is truly built in a macro dose type of environment. And so that is what the measure strictly allows. But again, it does not prohibit microdosing. And I believe that, there will be some folks out there that are certainly going to go that route. I think over time, we are going to continue to look at what's working and what's not working here in Oregon. And there's going to be an ability to continue to build out and expand this program to meet people where they're at and to really allow them to, safely, legally, in a regulated way, access the variety forms of psilocybin, from micro to macro doses, to other different things that we know we can eventually start to expand on after we get the program up and running, after we show that we've set the foundation that can withstand time moving forward.
Got it. Sam, thanks again. I think it's safe to say that we would love to stay in touch as we continue to move through this. I think, again, there's just so many lessons learned that we're going to want to kind of continue to glean from you. I would say if there are further questions or you think of additional questions for Sam or even for Angie after today, feel free to send those our way, and we'll make sure that we can direct those to Sam and Angie and see if we can kind of get some responses back that we could discuss at our future meeting. So we want to make sure that we kind of keep them in the loop.
Mike, quick
yeah.
point. I just want to address for folks that are not part of the committee or even are part of the committee, we cannot save the chat. So if there is something that you want to make sure gets recorded for a public comment perspective, please make sure that you send it to the website that we shared earlier, because our agency doesn't allow us to save Zoom. So please submit anything you want sort of documented for perpetuity into the public comment. Thanks.
Perfect. Thanks, Charissa. Sam, again, thank you. This was great background info, and look forward to staying in touch, and we'll make sure you get to your 2:00 on time.
Thanks, everybody.
Appreciate it. Angie, welcome.
Thank you so much, Mike.
Well, and you, Angie, I just want to confirm, you have control of the screen sharing?
Yeah, I'll share my screen and manage the slides.
Okay, well, we will turn things over to you and keep going on the Oregon front. So thank you.
Thank you, and hello, everyone. I'm Angie Albee. I use she, her pronouns, and I'm the section manager for the Oregon Psilocybin Services section. And I'm going to go ahead and pull up my slides. I want to make sure you can all see those. Is it coming through okay? Wonderful. Okay. And I'm sorry, I've been doing a lot of speaking all day in meetings, so I'm losing my voice a bit. I'll be sure to project. So just to get started, again, the Oregon Health Authority is, of course, your partner agency for those of you working in Washington for your health authority or your health agency. We are housed within the Public Health Division Center for Health Protection. I want to mention this because I think it's really important as you think about, where this is housed, really thinking about what's a good fit. We're housed within the Public Health Division. And if you look on our website, which I did drop into the chat, We're under the prevention and wellness side in the website, and I'll get to that in a little bit of why that's important. And it really does have to do with the structure of Measure 109. The other thing I just wanted to add is it's important to introduce to you agency priorities just very generally, because that really helps define the approach that the agency is going to take to this work. And so for one, the Oregon Health Authority has identified one single overarching strategic plan goal to eliminate health inequities by 2030. We're doing a lot of anti-racism and bias training, making sure that we understand how bias shows up in decision-making, how to center community, and how to ensure that we're really reaching out to communities who have been left out of the discussion for many, many, many decades. And so we're really working on that, and that's a part of what's shaping our work. The second thing is we're tying our work's goals also to the state health improvement plan. And so for Oregon, that's called Healthier Together Oregon for 2020-2024. You can look at this slide later for reference. We will get these sent out to you. I think I've sent these on to Mike. But the partnership identified 5 main priority areas, and I do think that this work fits into a number of those very nicely. I'm only sharing this because I do think it's important as you look at implementation that you're able to really tether the work and the implementation to the overarching goals that your state is working toward. So I'll just explain a little bit about my role. I'm the section manager that is leading the team that's implementing Measure 109. Measure 109 has been codified in statute, so it's in ORS 475A. And also I wear another hat, and that's as the ex officio executive director of the Oregon Psilocybin Advisory Board. I'll talk a little bit about the board later. I know Sam gave a great overview. But it's important just to note those 2 parts of this role for a little later. Our section is actually being designed and built through this development phase, which began January 1st of 2021 and goes until December 31st of this year. Our team is currently kind of constructed in 3 different program areas: policy and engagement, our licensing program, and then our compliance program. I'm going to talk a little bit about the Oregon Psilocybin Advisory Board. That was one of the requests that you all wanted to hear about. But I will try to get through some of these slides with you and highlight some important features about the work we're doing as you start to consider work for Washington and your recommendations. As Sam mentioned, the advisory board is directed to accomplish a number of goals, and I won't go into that too much because he did describe that pretty nicely. I will say that the board has been very busy and doing a lot of wonderful work. They were organized and appointed by the governor in March of 2021 and really organized into 5 different subcommittees so that during this development phase, they could make appropriate recommendations to OHA by the statutory timeline, which was June 30th of this year. They've already made that deadline and passed that benchmark. But they've been really focusing on those issue areas so that they could have a deeper dive into these issues to make recommendations so that they could look at equity. They could take a look at products and all the specific issues around products so that they could look at licensing issues. They could look at research and so it was like a really important way to give enough time for folks to really, center this work. And I didn't mention training, but that was another really important subcommittee as well. If you look on our website, the scientific literature review is available. That was the first benchmark that they had to meet by July of 2021. It was also translated into Spanish, but there was also a recognition that Indigenous communities have been utilizing psilocybin for centuries. There's wisdom that's not documented in what we consider to be, a very institutionalized setting. So there's an acknowledgement that while the scientific literature review is very important and research and all of this expertise that, is really showing up in medical and academic institutions is so important, there's also this other side that we can't actually, do a literature review on and make it available to the public. And what that means is we have to be mindful of how colonization and how oppression of our tribal and indigenous communities has, really affected the overall health of those communities and has left them out of the discussion. So I want to acknowledge that. And I also think that if you read the scientific literature review, you'll hear that the board is also working on compiling some of that cultural and anthropological information. I want to be pretty quick about some of these slides and discussions so that I can get to any questions that you might have in the time left over. But if you do have additional questions about the board, I'm happy to answer those. Again, they did send their recommendations to OHA in their final, not their final board meeting, but their final, voting meeting for those recommendations last week. And I won't get into this too much about what is Measure 109. I think that, Sam framed it really nicely, especially, as we have conversations, there's a lot of confusion about the differences between cannabis and psilocybin, and just the very nature of fungi versus a plant. There's a lot of, local governments around the state of Oregon who are really concerned about the impact that cannabis has had in their local jurisdictions, how much electricity or water or space, there's a lot of issues. And so we're trying to explain the different sort of structure and the regulatory structure with Measure 109. And at the same time, being supportive of our partners who carve the path with cannabis and all of the work that they've done. And so really describing that this is not a dispensary model. Psilocybin cannot be taken off site. In fact, the only place that psilocybin can be sold or consumed by a client is at a licensed service center. And so it's really important that folks understand that, as well as that this is available to clients 21 years of age or older for any reason. You don't have to have a prescription. You don't have to have any kind of diagnosis or referral. And in fact, Measure 109 is not a medical or clinical model. And so it's been very difficult. It's been a lot of work pulling partners together and think about the implications of the word therapeutic and what that brings up for folks. Or thinking about, for example, how we bring in our licensed professionals, into this work, which I'll get to in just a minute. But it's really important to note that. And as we start thinking about what measure, the implementation of Measure 109, really there's that understanding that this is the statutory container. And so this is what we're working within. We have 4 license types, and I'll just want to highlight them briefly. Manufacturers, this is not an outdoor cultivation type of measure, has to be indoors. I think Sam really, framed this nicely, but there's a testing lab license. Testing labs have to be accredited by our partners at the Oregon Environmental Laboratory Accreditation Program prior to applying for a license. So that's important to note. We have facilitators. This is a really interesting license type because they're individuals. And what the requirement is that they complete an OHA approved training program. We don't have licensing or regulatory authority over training programs, but we do approve their curriculum. And I'll talk a little bit about the rulemaking process that we expedited in a little bit. But it's really important to note also that facilitators are such an important part of this work. And it's important that we really bring communities together so there's representation at licensed service centers, so that if you're someone that identifies, with a certain facilitator, that there's a shared experience, a lived experience that wouldn't be triggering or traumatizing when accessing psilocybin services. We have the service centers. There's been a lot of talk of what this is and what this isn't, and how much this will cost. And I will tell you, we have not finalized rules yet. So, there's a lot of speculation, and we're going to be going through our rulemaking process, which I'll describe, that will focus on, all of these license types and all the remainder of our rules. I do want to point out that the service center, again, is the only location that can sell psilocybin to a client, and the only place that an administration session can take place. So kind of the way that this works is a manufacturer will sell to a service center after the product's been tested by a testing lab. And then the service center will sell to the client. And that's where the administration session will take place. We've been listening to a lot of feedback from the public, from partners, from our advisory board, our rulemaking advisory committees, and a lot of our public listening sessions to really understand, all of the information that's available, both in the research that's coming to us from all of these academic and medical institutions, but also from folks who have been practicing perhaps in other places where psilocybin is not illegal, and also folks that have been practicing psilocybin services or other psychedelic services around the world, and really drawing from their experiences. And they've done a great job of showing up for us in our advisory board and subcommittee meetings. So please check that out. We do have a great list of speakers that we've invited to those meetings. Psilocybin services is 3 parts. There's a preparation session. I know that the term screening and assessment has been one that has brought up, it's been a loaded term for a lot of our licensed professionals. And so it's important to note that client intake, informed consent, the client bill of rights, that's a part of this discussion around a preparation session and what that is. The preparation session is scheduled with a client and a licensed facilitator. And again, as Sam said, this is a time to make sure that psilocybin services are appropriate and that they're a good fit. Then there's an administration session. Again, we are still working on rulemaking, so I don't have a lot of details to share, except that we are listening to the community, listening to the public and our partners, and really trying to take the considerations of the advisory board recommendations and weigh those out as we draft up rules. There's also the integration session, which Sam discussed, and we're looking at a lot of those recommendations around what this looks like, and making sure that psilocybin services also can be affordable. OHA does not have, under Measure 109, the statutory authority to regulate the cost of products and services. So we have no authority to, to tell licensees how much this should cost. But we do, and we are a fee-based program, so the cost of all of this work has to be covered by license fees. And that's a really important piece to remember when you make recommendations is how is this funded, and what does that look like for accessibility and equity concerns. Product tracking, I think Sam covered that pretty well. This is a spore to sale tracking system, and it will track basically from the very beginning of manufacturing all the way until the sale to the client. And so we're working on that now, as well as developing our training program, licensing and compliance tracking and case management system. We refer to it as TLC, and we're just developing that system so that it's ready to go live by January 2nd, 2023. Sam discussed the local government issues, and the only thing I'll add to that is, aside from the ordinances that local governments can adopt to prohibit service centers and manufacturers from, operating in their local jurisdictions, is that ordinance has to be referred to voters at the next general election and passed by voters. They also have the ability to set reasonable time, place, and manner regulations, and a land use compatibility statement, or a LUX. I don't know what you call it in Washington, but this has to be provided by a manufacturer and service center before they can apply, or as they apply for their license. I talked a little bit about the structure and the funding of our work, but I also just want to mention that there's a 15% tax on the retail sale of psilocybin from a licensed service center to a client. It's important to note that we don't regulate the cost of those products, and so we don't know how much, what this will look like yet. We have some statutory requirements that, I think we've talked about overall. Again, all of our rules have to be adopted by December 31st of this year, and we go live accepting applications for licenses on January 2nd of 2023. I'm going to talk a little bit about some accomplishments and then really get into the rulemaking timeline so that I can turn it over to all of you to ask any questions you have. Again, this is a really high-level overview, and there's so much to talk about. So I'm happy to come back anytime if you have specific questions and would like more information. I'm not going to read all of these. I do want to point your attention to a couple of things. One is that we have public listening sessions. These are really important ways for the public to show up and be heard in this work. You know, there's so much knowledge and expertise. And so we actually created listening sessions back in December for our first round. And then we have some coming up actually in just a couple of weeks. We're providing Spanish, American Sign Language interpretation, and then also card captioning. But any other language or accessibility needs, we will definitely, you know, make available at the public's request. We also had a community interest survey that we administered in January, and we posted report findings in February on, it was translated into Spanish, Russian, Vietnamese, Simple Chinese, Mandarin, and Somali. And it's a really significant amount of folks that are interested in services and licensing. And so I would definitely recommend that you check that survey out when you have time. I won't get into these too much more, except to say that we are getting ready now for rulemaking. After our public listening sessions in July, we will actually start sending an invite out to the public and to our partners so that people can apply to serve on our rulemaking advisory committees and really discuss the draft rules that we're putting forward. And that will happen in mid-September. Those draft rules will be made available on our website and to people that sign up for our distribution list early in September. Then we will have these rulemaking advisory committees over the course of a few weeks. In November, the 1st through the 21st, we'll have an open public comment period where people can, you know, comment on rules, specific rule language recommendations, or other issues that we might not have seen or thought of. This is really important in the development of these rules. And although we've worked really closely with lots of partners, it's a really effective way to make sure that we're actually capturing information and also delivering and implementing in the way that Oregonians, you know, really find important. I've already talked about when we go live, and I'll just talk quickly about engagement. We've reached out to Oregon's 9 federally recognized tribes in our government-to-government agreement, and I think it's really important to both honor that government-to-government relationship and also consistently, you know, offer and open the door to any kind of communication. Currently, our tribes are sovereign nations that will tell us at any point if and when they want to engage. They've been really great about, you know, listening to the presentations that we've provided. And we had our tribal affairs director also present to our advisory board meeting to talk about that agreement. And I think that's a really important process. It's one of the reasons why our rulemaking timeline is so long, is to also give our tribal partners time to review our rules and weigh in. We've worked with psychedelic partners, academic institutions, the list goes on and on. The one I'm going to stop with and talk about a little more is our professional licensing boards. You know, as you've heard, this measure is, the statutory container is very open for who a facilitator could or, you know, could be. And we've had a lot of licensed counselors and therapists, social workers, psychologists, even some, you know, naturopaths, MDs and NDs, and nurse practitioners that are interested in this work and asking the question, can I be licensed as a facilitator? We've worked with all of our professional licensing boards to offer information, and really we're referring folks that are professionally licensed to work with their licensing boards and to really understand whether or not it's an option, and ultimately what are the risks associated with those options. And I think we all know, if you're a prescriber, there's the DEA licensure issue. And although I can't comment on that, it's really up to the licensed professional to kind of take a look at, you know, their decision making and the risks associated with that. At the end of the day, there are lots of licensed professionals that want to get involved in this work, and I do see it as an incredible need. This is a network, so you might have clients that come through the door that just want to have an experience. You might have folks that want to focus on one issue over another, or you might have folks that have complex diagnoses that might need a little bit more. And while the scope of practice for that licensed professional can't be practiced while someone is practicing under Measure 109 licensure as a facilitator, there's a lot of knowledge and expertise there for supporting, a client, and also what comes next for any kind of referrals or support services. So I just wanted to mention that it's a big discussion, and we've had a lot of licensed professionals and boards showing up with our rulemaking and our comment period, and we just really think that Measure 109 is also a great opportunity to bridge the gap between the Western medical model, the holistic model, and also between all of the licensed professionals, and also this network of folks that are really important to really reaching into communities and providing services. Similar to traditional healthcare workers, we think that this could be a really effective way to deliver culturally responsive services to folks in the community. I know I'm running out of time. There's a slide here that you can read later for opportunities for partner engagement, and our website. I did drop it in the chat box. I know that I need to be out. I have a hard stop at 2:30, and I think I was actually scheduled to end right now.
Oh, Angie, you're fine. You're fine. No, we can keep you on. I'd love to get even a few questions of folks if they've got it. Hey, Angie, before you wrap up, on your slide deck, there's one thing I wanted to clarify, if you wouldn't mind just bringing that back up, and it was on slide 17.
Absolutely.
The timeline. So just if you go down the bottom, I just wanted to clarify, I think, so we've got on June 1st, OHA begins accepting applications for the training programs. On the 2nd, it's accepting applications for the service centers. Like, is that correct? Is that the way you should be looking at that?
Yes, and thank you. I did want to dive into this a little bit for you all. We worked with lots of partners at the end, like the fall of 2021, to really understand what our needs were when we were talking about our rulemaking timeline. That's something that we plan as an agency very much in advance. And so we really recognized through the advisory board, through our partners, that there were a couple of levers that we really needed to pay attention to that could impact the entire part of this system being able to go live together on January 1st of 2023. Those two scenarios are testing labs. In order for testing labs to be licensed, they have to be accredited by ORLAP, but ORLAP would need time to set that accreditation criteria. So we expedited the rules for products and testing in order for ORLAP to get started, so that testing labs can go ahead and get accredited and then be ready to be licensed in January. The other lever that's really important is the training program scenario, and thank you for bringing this up. We recognize that in order for facilitators or folks that want to be licensed as facilitators to be able to apply for licensure, they would have to complete an OHA approved training program. And so we knew that we needed to expedite that rule set as well. So we worked with our advisory board to get early recommendations on those subjects, so that, and went through our entire rulemaking process so that we could adopt rules in time to really start accepting applications from training programs in early June, which we did. And we were really excited to get that system up and running. And so those expedited rule sets are the only rules so far that we've adopted for Measure 109. And again, we don't start accepting applications from folks that want to be licensed until January 2nd of 2023. But we are approving the curriculum for training programs and working closely with our partners at ORLAP on the accreditation criteria piece. So please go on the website if you'd like to look at those rules, and the remainder, everything else, all the stuff that we're seeing showing up in the chat box with questions. We haven't got to those rules yet, but we are drafting right now based on recommendations from the board.
Angie, thanks. I know we've got a few minutes left. I know you got to jump, but I'm just checking the chat. Sunil, I saw your question here on DEA. Do you want to throw that out there?
Yeah, thanks. There were some earlier questions, so I think Lisa Price had a question from the public, but my question is, and several, I think Renee also backed it too, we want to know if the DEA, if there's prescriber issues or any other licensed professionals, what is the DOJ, DEA said? Have they said nothing? Just let you guys continue your path, which is also a way of saying something. Have they said something? How is that relationship being managed, or can you give us a little insight into that? Because I think it's really important for people to have a sense of comfort. I mean, it's interesting, you have federally recognized tribes, and that's important, federal recognition. We also have federally recognized agencies. And I want to recognize them and make sure that we're actually working in some form of understanding, just like cannabis detente was done with with the Ogden memos and all the things that sort of have slowly eased some of the tensions in the room that had been there.
Yeah, thank you so much. So this is a great topic, and probably we could talk about it for a very long time. So I encourage you all to, definitely spend some time on this. As far as Oregon and working, we'll continue to work with our federal partners as much as we're able to. At this point in time, we have not received any guidance from federal partners, from the DEA. And I know that there's a lot of work happening. And I know that Measure 109, because it's not a clinical or medical model specifically, it's something that encompasses many things. We live in many spaces in Measure 109. I think that that's something that, perhaps is a little tricky for maybe our federal partners to really, work with. And I would just say that part of Measure 109 directs us to work with our advisory board leadership to try to, make an appointment to meet with our federal partners, the U.S. Attorney for Oregon, and have a conversation. We don't have a Cole memo like cannabis did, even though it was, pulled back later. But that gave some, assurances to licensees that they wouldn't be raided by the federal government. We don't have that here. But what we do have is just a phenomenal amount of research and evidence that's pointing towards the potential benefits of psilocybin. And so that's the difference. And I think that I don't know if we'll hear anything concrete. I'm not certain, and we will complete our statutory responsibility and move forward and carve out this path with other parts of the nation that are doing the same work, and hoping that we continue to be able to be successful.
Awesome. Angie, again, I can't thank you enough. I probably the same offer with Sam. I look forward to probably staying in touch and continuing to kind of get some lessons learned from you guys as this group continues its process.
Thank you, Mike. Absolutely. And may I make one more? I forgot something that I think is important for this group. Please. I'm going to mention it quickly. Implementation timeline is very important. Giving a state agency enough time to implement. We were given 2 years, and although our timeline started January 1st of 2021, because of the way it works with position authority and getting enough funding from the legislature to start up, I wasn't able to be hired until June. So, really it was more like an 18-month implementation timeline. And because there's so many pieces to development, and even though we're on time, we have a great team of 6 people, small but mighty right now. We're waiting to build the rest of our team out. I think that that's really important. So I just want to encourage you all to think about that, as you move forward, and planning and just being really insightful and thoughtful, and giving community and partners enough time to process this and work with us is incredible. And so I just highly recommend that you give enough time for implementation. Awesome. And it's great to see you all. Thank you for the invitation to be here, and I'm happy to come back anytime.
Awesome. Angie, we'll take you up on it. Thank you so much.
Thank you. Have a good day.
Thanks. Hey, before we jump to the next section, Charissa, do you want to jump in?
Yeah, just want to say a couple things. I've been monitoring the chat, and there was a question about, are we going to vote on any of the stuff passing around in the chat today? We hadn't planned to do that in a structured way. So I think without that planning, we can certainly, have some decision making next week. The other thing I want to just remind folks of is we don't have a Measure 109. We are not responding to the breadth of that, nor the elements in it, nor whether or not we agree with Oregon's process, position, or stuff. We are asked very specifically about the things that were revealed in slide 4. That said, this group can certainly make recommendations to follow Oregon's path in terms of We recommend that a strategic advisory board, including XYZ, be formed. We recommend that. So we just a reminder to the group, our scope is much more narrow. We are not expected to, nor were we asked to create a whole structure plan like Oregon does. So I want to remind folks that that is a huge amount of work they're doing and have been doing. So we don't have quite that broad a task. We can recommend those things be done in the next iteration, but just wanted to remind folks of that.
Charissa, thanks. And I got to thank you guys too. I mean, you've kept the chat box busy, which is great. I mean, I think that's gonna help us really kind of get a better understanding of kind of your thoughts and needs, even for the next several meetings. So I think there's going to be a lot there for us to take away. So I would say just keep that going, and we'll make sure that we can continue to track that. Beth or Cody, if we could bring up the slide deck again. So we got a half an hour left. And what I wanted to do was spend some time and kind of go through the results of this survey that you guys took, but then also kind of go through a facilitated discussion, because a lot of the results that you guys put out there kind of warrant some further discussion. And I think that's what we really wanted to kind of dive into today. And I think I also want you guys to realize that the survey closed on the 28th, just a couple of days ago. So we did our best, our team kind of did our best to kind of extract some of the key themes and some of the main points that may have been some overlap. We put those on some slides again to kind of generate some discussion. You will see the full results of the survey in the following week or weeks after we can kind of go through and make sure that we can kind of have this in a nice PDF, and we'll put that on the website so everybody will be able to see that. But for right now, we did our best to kind of consolidate, get some really kind of key themes up there so we can kind of generate some discussion. So with that, why don't we go to the next slide? And just to highlight, so we had 14, I think was a good number, knowing kind of the folks that we have on today. So that's what we're looking at today, the 14 respondents. The next piece was just this first question of how familiar are you with the Oregon model on a scale of 1 to 5, 5 being very familiar. So you see majority, we're at 3, and then kind of some 4s and 5s. That was before we just had this presentation today, or both of them. Hope is that it gets a little more over to the right, that many of you are a little bit more familiar with the Oregon model after what we just went through. If you're not, and if there's more information you want out of Oregon, again, that's something that we would ask that you would kind of request of us. If there's more information that you want, that we can kind of get out to you in advance. So again, we want you to make sure that as you are doing this evaluation of what's working, maybe what's not in Oregon, what you would want to be applicable to Washington, we want to make sure you have the appropriate information. Next. So we asked a question from what you currently know about Oregon's program, what elements should Washington look to duplicate? And there's some stuff that was already in the chat. So you heard Angie talk about this 2-year period. So somebody echoed that, saying, yeah, I think that 2-year period is a needed thing that we would look to duplicate. A comment there on end of life. Focus just on the licensed centers to start. And then, I mean, you guys have done a great job of filling out this chat box right now on this last bullet point. So what Oregon did was pass Measure 110 at the same time, and this unauthorized possession of fewer than 12 grams, right? Reduced misdemeanor to a Class C violation, right? So this is something that we haven't talked about, but you guys kind of brought this up. And again, this could be part of your recommendations, that if you were to move forward, that you would be making a recommendation to the legislature that, hey, we really should be looking at something like Measure 110 at the same time. I want to stop there because there was a lot of comments on this, even in the chat. So anybody kind of thoughts, comments, want to weigh in here?
I can jump in. Just to keep it quick, of that, passing Measure 110 and Measure 109 at the same time was was an important thing that they did for both access and equity, and also around the anti-oppression practice of not perpetuating systems of oppression. In order to, the price for psilocybin service centers will likely be high if it's not subsidized by health insurance or some kind of philanthropy support. And greatly, we just don't know what those price points are actually going to look like yet. But having a trained facilitator there for 6 to 8 hours is a lot of money. And so having access for people to do this in a way where they're protected from being arrested is incredibly important. And it also intersects with the reality that many of the people that are, in jail for drug possession, people who are getting arrested, are people in the Black and brown communities. And so if we're looking to not perpetuate this, then we need to have decriminalization alongside regulated use.
Thanks, Emma. Yeah, that's helpful to hear. Jermaine, I saw you have your hand raised. Oh,
Here
you're
I
muted.
am unmuting. Yeah, I just had to unmute. I just wanted to say that if we work towards something that has to do with decriminalization, like this last bullet point, what I'm struck by is possession of 12 grams, more than 12 grams, 12 grams of actual fungi and 12 grams of psilocybin are two really, really different things. And that's not even clarified there, so some of those kinds of things I think we really need to have a look at, because refined or extracted chemical, 12 grams of that is probably 10 times as much as is available in 12 grams of mushrooms, dried or wet or whatever. So it's just a point that in this issue of decriminalizing, if numbers have to be produced, we also, I think, need to be specific about when we talk about something like a weight, the weight of what?
Jermaine, thank you. Others, Cody, I saw you had your hand raised.
Yeah, in terms of decriminalization, I know the folks in Oregon, they'd have much less to worry about in terms of transportation, in terms of manufacturing, possession, when it comes to the fact that they did pass 110 at the same time. And I think it just makes it much less of a regulatory headache in order to pass a similar measure to decriminalize it at the same time, rather than just having this system where it's still criminalized under state law, but we have like this service center model, and it just seems like it makes things much more complicated than they should be.
Yeah, good point. Do I have other hands? Neil, do you have your hand raised?
Yes, thanks. I was just saying that I think Colorado also is doing, and probably people know more on this in this group, but also doing decriminalization at the same time in a much broader way with their psilocybin services sort of model that they're putting forth. So Washington, it's not just looking at Oregon, we can also see kind of what's being on the docket in Colorado. And of course, as policies evolve, things get better each year when people kind of learn from the previous one. So, but it also gives us a little bit more cover to do that if our Oregon and Colorado are doing that.
Neil, it's a great point. And I'm going to kind of sneak peek for our next meeting. We've got our colleague at the center, Duncan Stewart, has done some amazing work of doing kind of some mapping at the national landscape, so state by state breakdown, and starting to see some of that. And I think that'll be helpful at the next meeting. We'll start to explore some of that so you have a better understanding of what's happening kind of state by state. If we can go to the next slide. So same thing. You're really looking at what you would look to duplicate. So education. This next one is interesting because, again, you guys had talked about this in kind of two buckets. One being kind of licensed behavioral health professionals, but this one kind of mirroring Oregon, where you're saying really anybody with a high school diploma who can kind of go through this training program would be eligible to be this facilitator. And again, that's something that, again, we'll be looking to you guys in terms of what is going to be potentially that final recommendation of what you would want to see for that training population. Limiting kind of the type, starting with licensed centers, and facilitator training being universal. Any thoughts, comments? Anybody want to weigh in there? Okay, why don't we go to the next? Oh, I missed one. Cody, go ahead. Sorry.
Oh, yeah. Just a comment here in terms of what Oregon does in terms of their training model. I really do like what they have done in terms of making it allowable for anyone with a high school diploma to have access to that. I think increasingly in a variety of career areas, we're seeing what is education inflation, where you continually need higher and higher levels of education for various professional roles when that's not necessary, and that puts it out of the reach of many disadvantaged communities and socioeconomic classes that might not otherwise have access to those opportunities. So I just want to make that comment.
Thanks, Cody. Tony, I saw your hand raised.
Yes, I've actually got I've got a comments about the current slide in terms of looking to avoid or modify. Can I jump into that, or should I wait?
I saw, do we have one more? Any other on this?
Yeah, I've got a quote about the previous slide. But
yeah, Tony, hang on to that for just a second. We'll get there. Yeah, Sunil, go ahead.
The limiting psilocybin cultivation of cubensis, I just thought it'd be worth saying something about the fact that we have a lot of biodiversity in fungal populations that produce psilocybin. Somebody said hundreds of species earlier. I think Renee from Fungi Perfecti. So it doesn't make sense to me to keep a monoculture, because that's not really the natural history of human fungal psilocybin fungal use. So I understand there's more complex issues. There's different ones with different ratios, but it's not like it's something our ancestors have been dealing with just fine. So I think we'll be all right.
Thanks, Sunil. Renee, did you want to add on to that?
Sunil just made my job very easy. That's I'm probably going to say that. Yeah, I understand, limiting cultivation to one species, and really lots of people in our area are gathering cyanescens, other species, some type of research framework to understand what is going on with some of these other species would be very helpful for all of this. So thanks. Thanks, Sunil.
Got it. Emma, did you want to weigh in on that too?
Nope, mine's for the next slide.
Okay, why don't we go to the next slide and we'll start with Tony first.
Yeah, one issue that's come up with Measure 109 in Oregon is that the measure did not just explicitly discuss whether training programs need to be approved by the state agency in Oregon that regulates and approves career schools. And at the very last minute, that agency spoke up. I think it's the HECC, if I'm correct.
That's right.
And they said, yes, we have to approve all these schools. And by the way, it's going to be 18 months plus for us to approve any of them. And, this was all at the very last minute. I personally, in an unrelated project, am part of a new therapist training program that's applied for approval in Washington State from the Washington Student Achievement Council. And it looks like it is a 2+ year waiting time to get the application looked at. And this is for a non-controversial standard therapist training program, very run of the mill. And so I would encourage us for this bill to include explicit language that the training programs do not need approval from the Washington Student Achievement Council or any other state agency. Thank you.
Okay, thanks. So yeah, what you were referring to is the HEC, the Oregon Higher Education Coordinating Commission, and it did. You're right. It just got punted to them to kind of try to figure this out, and I don't think people were necessarily anticipating that at the beginning. So that's good. It's a very good point. Emma.
Yeah, thanks, Tony, for bringing that up. I was going to say that. So what Tony said, and then additionally, something that I've experienced in coordination with a lot of people in Oregon is the issue around tiers of training. Of that, people mentioned it before. There's a really wide variety of types of facilitation and types of work that people are trying to do with psilocybin, right? All the way from just general wellness to having spiritual experiences to people like I work with who have complex PTSD or other dual diagnoses. The level of training that's required for effective facilitation in all of those different groups is very different. And so something that I would love to see Washington do is recommend that there be a variety of levels of facilitator training versus one. And that goes back to access and also safety.
Got it. Thanks, Emma. Any other thoughts on the first bullet? I saw some stuff in the chat earlier, just in terms of kind of where folks are aligning on even on the microdosing. Cody?
Yeah, so in terms of microdosing, it seems to me to be a bit silly to have folks sit around at a psilocybin service center for 6 hours if they're taking a sub-psychoactive, sub-threshold dose of psilocybin. And I really do think that's one area where us folks in Washington can improve on the 109 design, and we can settle that debate here. And I think that should definitely be an option for those who are looking for it. I just want to clarify my thoughts on that.
Got it. And I don't know if anybody has thoughts on the second. Oh, Charissa, go ahead.
Yeah, no, not well. I wanted to just follow up on Emma's comment. I think, again, I'm going to be really annoying in these meetings, but we are the healthcare authority, and we deal with healthcare. So I think it would be useful as we have these conversations to sort of frame our recommendations in a way that Emma just laid out. People who are looking for a spiritual activity or well-being versus people who are working through complex trauma versus people who may have underlying behavioral health conditions who may be interested. Those are all very different populations and needs of I would say, screening, review, sort of preparatory, session, and then follow up. So I would hope that we would, as we go through this, think about this. And I think I do want to hear from our clinical experts on the team, what their recommendations are regarding sort of the clinical utility. That's not the sole program of this, but again, we are the healthcare authority, and we can't submit a report to the legislature without sort of commenting on how it fits within the healthcare schema. And I hear from the group that the evidence is very clear and settled. In my review of what Oregon looked at, I think there is absolutely promise, huge promise, and suggestion of efficacy. Does it spread across all populations with all conditions? I don't know. So that's why I would love the clinical expertise of this group to weigh in on that when it's appropriate. But I do think sort of thinking in those different groups of participants makes some sense. I would hate to have this group put recommendations forth that people could come back and say, oh, well, you wouldn't want to have so-and-so do that. So I just might offer that as an option for us to think about.
Thanks, Charissa. Sunil, I saw you hand raised.
Sorry, that was in a different window. So I was just going to comment about this question of what the Guild of Health Professionals who have a specialized training already in complex issues like mental health conditions or physical health conditions or what have you, and the people who need our care. And I think it's nice that we have a system like health insurance that does limit the costs for people for accessibility for that, so that we can still, I wanted to think about creative ways to utilize that and not have to put that on, the whole psilocybin service center, because it's a user or seeker, because you can actually still do that. Now, yes, that's why I had some comments in the chat earlier. Like, how do you? But psilocybin is still Schedule 1, and psilocybin, we haven't had a huge evidence-based review, from FDA or health authority or any group. There are nice reports and summations out there that show safety and efficacy and in controlled settings and historical use. So you could say, well, all right, there's a piece of this that insurance can't cover, but there's a piece of, or third parties, but there's lots of pieces of this that it can cover. And I think that's a way you could people could still seek out specialized care for folks who have the dual training. But I don't know if it's a good idea to create a tiered licensing when there's already a license for health professionals, and then you have maybe a license for licensed facilitators. That was just my 2 cents on that thought that you were raising, Emma. Thank you.
Caitlin.
Right. So, and I also have questions to you. We run into this in cannabis a lot, that folks assume we went the other direction and assumed all cannabis use is recreational use in the adult use market. And we lost a lot of patients in the midst of that. And we discovered that a lot of folks may not be identifying how they're using cannabis medicinally, particularly around mental health issues. And so when you create that two-tier system, it's sort of how do we funnel people into the right hands as practitioners. And again, from that cannabis perspective, we've lost a lot of responsible care towards patients because of that assumption of non-medical application when it's probably there.
Got it. Thanks, Keelan. Cody.
Yeah, I just wanted to, address the comments made before about in terms of making these recommendations to the legislature and, being in the context of, whatever medical application there is. And, I do want to be clear, I do think that there are fantastic medical applications for psilocybin, particularly in the realms of depression, in the realms of PTSD. But also, in terms of if people want to use this purely for a placebo effect, I think, maybe there are some populations that should not use this, such as those who have a genetic predisposition towards psychosis. But I can't really think of too many other groups of populations that where this would potentially be a risk. And so, I wouldn't try to limit this too narrowly in terms of who should have access to psilocybin and what sort of medical conditions are we picking and choosing for this to potentially be applicable toward.
Let me be clear. That's not what I'm suggesting. I'm suggesting there's a difference in recommendations that would encompass people who might be predisposed to psychosis or someone with schizophrenia. Having sat in the ED with people who were on bad trips, it can be quite frightening. And for an unskilled facilitator with a high school diploma, that's a handful. Taking care of folks. So I think all I'm trying to say is I think we need to be cognizant of the breadth of people that might access this and how we couch our how we frame our recommendations with that knowledge. Not to say we have to limit them, not to say we say it's only for this group. That's not at all what I'm suggesting. I'm just saying I think people are different, how they respond and their risks are different. And Nathan, I'm sorry, you're a real doctor.
Oh, no, it's okay. Yeah, I wanted to comment on that too, that, the concern I have about the Oregon model is this issue of if you're reducing or removing the kind of medical model paradigm, then who's the gatekeeper? And while I agree, psilocybin does suggest, that the literature suggests that psilocybin is profoundly safe from a pharmacologic perspective, but there's a lot of unknowns. I mean, there's a lot of potential drug-drug interactions. And while I think the risk is relatively low, I think there needs to be a way for us to think about, if you're taking a number of meds, there is some risk and we need to better understand how to mitigate that risk moving forward. And so I'm still hung up on how do we manage that from a medical perspective? And if we're moving towards kind of this consumer model like in Oregon, are you going to have these psilocybin centers say you can't do this because you're on these meds? And it just seems, I'm confused by that, I guess.
Fair point, Ethan. Thanks. Emma.
Nathan, thanks for that point. I think the only thing I would add to that is that the medicalization model, I would see it's not the gatekeeper, it's the safety net. And my understanding, at least for our committee, is that our job is to recommend what's on the bill versus decide how the bill gets implemented. And so from me, my perspective is let's just make that as big as possible. Because if we say, okay, we want to look at a potential for a tiered model, we want to look at how the different ways of access that people are going to have to psilocybin, we want to give ourselves as much room as possible for whoever the next committee is to actually decide what the implementation looks like. And if we pigeonhole the recommendations, then we could be shooting ourselves in the foot ahead of time and not creating space for something that we realize we need space for further down the line.
Thanks, Emma. I think that's a very valid point. I don't see any other questions. I see a thumbs up from Caitlin. Thanks. I know we're going to be running out of time, so let's keep going through the next few slides and we'll continue some conversation here. So the next one, same thing. What would you want to look to avoid or modify from the Oregon model? Don't see a need to have a distributor between the grower and the end user. No provisions for exemptions of personal, religious, or indigenous uses. Targeted populations, that's like we were just kind of talking about. And Oregon specifically prohibited interstate transport. Again, thoughts, comments here, we can keep moving. Let's go to the next. So this one, we asked you to prioritize kind of a forced ranking, prioritize the categories below based on their level of importance in shaping a future program, 1 being most important, 5 being least. You'll see from left to right, you've got safety and clinical effectiveness had the most number 1s. Then equity had the most number 2s there, and then access and affordability. So the way you're kind of laying this out, if you're looking at kind of how you want to prioritize these areas, you had safety, clinical effectiveness, and equity were kind of those top 3 that you guys put forward. So when you start thinking about kind of that formation of that program, these would kind of be those cornerstones. Charissa, please.
Yeah, a plea for help from this committee as we develop these recommendations. I think it will be very useful for our ultimate submission of the report if we can, and this may not be easy, define what we mean by equity, access, and affordability. We all assume we know what they mean, but we might have slightly different versions. And again, I think I keep copying Emma, but we want to present a breadth. And so if we're talking about things like access, affordability, and equity, I would hope we'd be able to provide some specificity around that so people don't have to interpret what we mean if we can come to some agreement.
Great point. Thanks, Charissa. Okay, got 6 minutes left. Let's keep going. We got a few more here. Any other categories you'd like to see prioritized? Advancing research, not interfering with pre-existing Indigenous practices, equity, access, affordability, much like we just talked about, and then laws being flexible enough to allow for new innovations. Again, you're going to have a much more comprehensive kind of overview of all of these results. If I can go to the next slide. So we had a couple here talking about what are the biggest opportunities to develop this framework. You guys have already mentioned this huge unmet need. Improved mental health and well-being, potential reduction in crime, thought leader, clarifying regulatory pipeline. So I mean, all of that, again, you got some more comments around that. I want to hit the next one though. The next slide talked about kind of these bigger challenges and concerns. Department of Health may not have the framework infrastructure. We talked about this earlier, intersection of behavioral health licensing boards. Just to stand up this regulatory framework. Don't underestimate the complexity of actually doing this. Clarifying regulatory pipeline. And there were more comments around that, but these were kind of these overarching kind of common themes. I had one more slide on that, but does anybody kind of want to weigh in on this first one? Okay, let's go to the next. Again, Tony, go ahead, please.
Thank you. In terms of the standing up enough a workforce to provide services, I think one of the real strengths of the Oregon model is that they're only requiring a high school degree to receive training and provide services. And believe it or not, that is, a lot of people don't know this, but that's actually supported by the empirical research, which over the past 5+ decades has generally failed to find a difference in mental health services provided by licensed professionals and paraprofessionals. I'm happy to provide a lot of literature on that topic if necessary. I know that is one part of the Oregon model that people sometimes have questions about, but that I think is going to be a major advantage to Measure 109 in terms of standing up a workforce. Thank you.
Awesome. Thanks, Tony. I know we got 3 minutes left. Yeah, Emma, go ahead.
Thanks. I'm totally on board with Tony. I think having the access be a high school degree is really important. And in terms of creating a robust workforce, I think it's like absolutely critical that part of the initial process is talking to the state license boards for healthcare practitioners. Because if we get to the end point and anybody with a healthcare license can't do this without fear of their license getting taken away, that's going to be a huge problem for the section of people that are looking for robust mental health care access.
Yeah, thanks, Emma. I know we have one more slide there on biggest challenges and concerns. You can see those there, corporatization, access around disadvantaged communities, ensuring safety, obtaining DEA, FDA legal permissions. We guys talked about that earlier. Sunil, yeah.
Yeah, I mean, there's not enough time to discuss these really deep issues, so I hope we can come back to these two slides and dive a little bit deeper, because these are really weighty topics that hopefully we don't have enough time really like to unpack. Is what I was going to ask about.
Absolutely, that is the plan. This was, again, this kickoff meeting, and Cody, I know you were asking if no voting today. Really wanted to kind of give you an overview. I think this survey was nice just to get an input from you guys ahead of time of kind of where you guys are. We can take a lot of this and start to guide what those future meetings look like. I wasn't anticipating the chat going like it was today. It's fantastic. So we've got a lot of work to do just to kind of unpack a lot of that work. And you guys posted articles and all of that. It's fantastic. So there's a lot for us to take away. We're going to tee things up for the next meeting. I'm kind of looking to Jim Morgan from Liquor and Cannabis Board. We may hear a little bit from them just on overall tracking of how they would potentially go about this. But we've got more to do on probably some organ updates, more to unpack all of these slides that you just did. And then more to even understand what's happening at the national level with kind of a state-by-state comparison. Charissa, before we depart, any kind of last minute observations, thoughts?
Yeah, no, thanks. I think this has been a great discussion. I'm really impressed with everybody's knowledge, willingness to lean in and, figure out how we can set up the next iteration of the legislature and moving their push forward. So looking forward to future discussions. I appreciate everybody participating. Please continue to do so. It's sometimes hard on Zoom, but please, I hope we all consider this a conversation as opposed to being talked at and being told. So thank you for your attendance. I thought it was a good session, and please let's have continued further discussion as we go along. And Mike, thank you to you and your team. I think you did an excellent job preparing the meeting and setting it up. And Cody, thank you for making sure that everybody's in the right place at the right time and we have all this information. So thanks all to everybody who helped put this together today. And the
participants. Great group, guys. Looking forward to the future. This is great. Okay, thank you guys. Have a great afternoon. Take care.
Everyone, take care.